Hello everyone. Another video tonight about the lower respiratory diseases. So this time we're going to basically cover everything that affects the trachea, the bronchi, and the lungs. So let's get started. The first disease that we will discuss is acute bronchitis. And what acute bronchitis is the inflammation of the bronchi. Pretty much they're open, airway, it's considered an airway, and air basically just flows easily through these pipes that we have. But whenever they are inflamed, swollen, and filled with mucus, air cannot easily flow through them. Think about the bronchi as a straw. You drink more water out of a big straw, like, let me see who has a big straw that I could think of, like maybe a Sonic straw, versus a tiny cocktail little straw. It's less fluid that goes through, less water, less cocktail. Well, the same thing happens with the airways. There's different causes. One of the main ones, or the most common, is viruses. It could be viral, it could be bacterial, it could be irritants. Smoke can lead to bronchitis, and hot or cold changes, especially if you suffer from bronchitis often. It can exacerbate by just different weathers and hot and cold. How does it manifest? Well, you have this annoying, nagging, persistent, irritating cough that is very strong, and sometimes even people call it like a bark cough because it sounds like a dog barking. It can last for weeks, and it is the most common symptom. You have difficulty breathing because the air is not passing through. You can have chest pain. It is not cardiac pain. It is from the coughing so often that your muscles just become so sore. You feel or you hear a wheeze. A wheeze is a sound that it makes when air is passing through these narrow airways. And it just sounds a little bit like this. I'm going to try to imitate it for you. Just like that. It could be sometimes faint, very subtle, or it could be like really severe. But pretty much it's just air passing through a very constricted and narrow space. You could have clear and purulent sputum, fever, and headaches. You diagnose bronchitis basically mainly on clinical evaluation and symptoms. This cough and the wheezing, it gives it away almost. However, you still could do like sputum culture to see what's growing, to see if it's bacterial, the problem, or have an x-ray. The complication of bronchitis is pneumonia. And here shortly, I'm going to go over of what pneumonia is. So hold on, okay? How do we treat it? Well, we treat bronchitis with mainly avoiding the irritants. If it's smoke, stop smoking. Stop being around people that smoke. If it's infection, then let's treat the infection. If it's maybe irritants, I don't know, toxins or so, then you need to protect yourself. Lots and lots of fluid. The swelling, the inflammation that happened produces this mucus, and so we need to thin the mucus, and for you to be able to, for the patient to be able to expectorate and bring it up, and so they could cough it up. Rest, humidifier and steam. Heat and steam opens the airways, and so that's what it's used for. Cough suppressants, they're coughing a lot, they get tired of coughing. And so one thing that we can give them is something over the counter that you probably have heard. Brand name is Robitussin or dextromethorphan. Expectorants, again, you expectorate, you bring it up and you cough it up, as commonly brand name Mucinex or generic name Warfarin. There's commercials about Warfarin because there's like this little green monsters, and they get eliminated. You probably have seen the commercial. You can do bronchodilators if your bronchus are pretty narrow, like albuterol. You can do antibiotics if it's bacterial or antiviral. But again, antivirals, as I mentioned with flu in my previous video of upper respiratory diseases, you have to take them within 2 days of the onset of symptoms. You can do honey, throw lozenges in hot tea just for throat comfort and the cough, and wash hands frequently to basically prevent it or spread it out, okay? So pretty much here we want the airway to be open because you have very constricted and swollen pipes, airway pipes, and anything that helps the mucus come up and down below airways to open, like bronchodilators or steam. Let's move on to pneumonia, which is the complication of bronchitis. Pneumonia is an acute inflammation/infection of the lung parenchyma. And the lung parenchyma is that functional part of the lung, what basically does everything for us, called the alveoli. The alveoli, as I mentioned in the general overview of the respiratory system, is the one that it's responsible for the exchange of carbon dioxide and oxygen. So when these alveoli are damaged or sick due to an inflammation or infection filled with fluid, the exchange of carbon dioxide and oxygen does not happen. Now, let's talk about a little bit of the pathophysiology. How do we get to pneumonia? Well, pretty much we have many defense mechanisms that protect the lung from invaders. We have our cough reflex, we have the filtration of the air that goes through our nose, and we have little hairs in our nose. We have the epiglottis that covers the trachea. We have this little hairs in our airways that move things up and don't let them get to the lungs. And we have the immune system. And whenever there is a alteration or a break in these defense mechanisms, then you have something invading you, and you have something that is not supposed to be in the lungs that is infectious or not sterile, we'll call it. So that causes an inflammation reaction, and then the inflammation and the immune system starts producing exudate, which then interferes with this exchange of the carbon dioxide and oxygen. Pneumonia's most common cause is the most common cause of infectious disease in America. Is the 5th leading cause of death in the elderly. So a lot of people die from pneumonia. Who's at risk and or what causes it? Well, there's different things that can cause it or who can be at risk, and it depends. It depends on these mechanisms of defense. So let's talk about a few of them and let me try to explain them to you. So people that have surgery. So when people get surgery, they, first of all, a tube goes down their throat, which is called an intubation. That can cause bacteria or can bring bacteria into the airway. But not only that, is after they get out of surgery, they're not moving and expanding their lungs because maybe they're in bed, they have impaired mobility, and that leads to atelectasis. Atelectasis, and I'm going to talk further in depth about atelectasis, but atelectasis is the collapse of the alveoli. And when they collapse, again, they're not expanding, they're not exchanging the carbon dioxide, and that leads to pneumonia from just things being built up in there. Another one is age. As we age, we don't have a great immune system response. We lose the little hairs in the trachea, etc. We have also a decrease in cough reflex. Smoke is another one. Gastric feedings, if someone is getting an NG tube with feeds or some type of supplemental feed, they can aspirate food or GI content. And again, that's not supposed to be in the lung. Altered consciousness, when someone is either on narcotics or have some problems neurologically going on, they can aspirate saliva, and saliva, the mouth is very dirty, and so they aspirating the saliva can lead to bacteria and things like that that are not supposed to be there. Chronic diseases, and also people that have suppressed immune systems. How does it manifest? Well, the first typical symptom, if you catch it on time, is confusion because of the low oxygen. On my previous video of the respiratory system, in general, I talked about how oxygen in the brain, every tissue needs oxygen to survive. And so especially the brain. So whenever the brain is not getting oxygen, you tend to have this irritability, confusion, and that's usually one of the first signs. Cough could be productive or non-productive, and also it's yellow, green, or brown. So you have a tinge of color to the sputum. You'll have fever, chills, and then you have this famous, commonly known lung crackles, coarse crackles on auscultation, where you hear when you place your stethoscope, especially in the bases of the lungs, you'll hear wetness, what sounds like crackling and popping kind of thing, of sort of a sound. It is basically the air moving with fluid. You have difficulty breathing, you have tachycardia because your cardiac system is making up for the lack of oxygen. You will have this pleuritic chest pain when they take a deep breath in. That is very known to pneumonia. When they take a deep breath, it hurts. Their thoracic cage, their lungs hurt. You have fatigue, headaches, body aches, and in elders, you could have hypothermia instead of fever. Sometimes that's seen. In the elders, we have different symptoms. Here's a little picture, funny picture of the crackles. They describe it as snap, crackles, pops. And again, it just sounds like that. They could be very faint, so you have to train your ear to hear them. But yeah, they sound like, something like that. I'm trying to, as best as I can, make it up for you. But you can go to YouTube and search for the sounds and you should be able to find plenty of them. How do we diagnose it? Well, there is some key diagnostic testing for pneumonia. And I'm not going in particular order of priority. I'm just in general, the star ones, the ones that I put stars, and you notice my stars are important, is chest x-rays, because on the chest x-ray, as if you see in this picture here, you see white patches. A normal lung filled with air and not collapse alveoli when they are, in their proper size, they're black. They're black. So dense material or fluid reflects in a chest x-ray as white. So you'll see that here as you're looking at the photo on your left side, you see all those white patches. That's pneumonia. Also a CBC, because you're going to find your white blood cells are elevated because it's an infection. You're going to have oximetry. You're going to have a low oxygen saturation. You're going to have arterial blood gases with a elevated carbon dioxide and a low pH. When you see the acid-base imbalance lecture, this will make more sense. You will collect sputum cultures to see what's growing. It is very highly recommended that you do not start antibiotics before obtaining a sputum culture. Now, let me tell you something. That is the ideal world. You need to obtain a culture before you start antibiotics. However, if the patient comes into the emergency room and says, I've been coughing and hacking for days, and then you say, oh, here's a little cup so you can spit in there your sputum, and then they tell you, oh, I don't cough anymore, I can't. You don't delay treatment. You're not going to say, oh, well, I can't give you antibiotics until you give me a sputum culture. No, we just attempt to get it, but we're not going to delay treatments because this is life-threatening, and the bacteria can spread to the blood. It can spread to the whole body and cause sepsis. That is why we do blood cultures to verify, to see if it's spreading to the rest of the body through the blood. And then there's something that the book talks about called C-reactive protein, which basically is a protein general that elevates when there's inflammation. Now, it doesn't have necessarily related to lungs or cardiac, or it just in general, when there's an inflammation response in the body, C-reactive protein elevates. How do we treat it? Well, we treat it with, as you're going to see, a lot of things is preventing them, educating the public. And so educating the public about that we do have a pneumonia vaccine, a streptococcus pneumonia vaccine. It is recommended above the age of 65. Is given and highly recommended to people with comorbidities or these big diseases. Also, it's given every 5 years, not every year like the influenza. But let's say you got it despite that you had the pneumonia vaccine or not. Well, we got to give antibiotics to treat the infection and to prevent any further complications or death. We're going to give them a lot of fluid, because again, I need to thin the mucus so that way they could bring it up and cough it up, and also hydrating and maintaining my blood pressure. I'm going to supplement some oxygen. I'm going to elevate the head of the bed. That allows for lung expansion and for the patient to be able to breathe better. I'm going to encourage the turn, cough, and deep breathe. This should be done every 2 hours. If not, get him up to the chair, get him up walking. but at minimally turn, cough, and deep breathe. You're going to also encourage the insert of spirometer so they can expand those alveoli and start coughing things up. There is something called chest physiotherapy. It's like percussion, and I put a vest here. This picture of the vest, that is what chest therapy is, or chest physiotherapy. It's mostly done by respiratory therapy, at least that's where I've seen it. And then they put this little vest on you, and the vest just like tuck, 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 vibrates and percusses, excuse me, on you. And what that does is to basically help to loosen the mucus, and so the patients can cough it up. You're going to encourage a balanced diet with, protein and vitamins and good nutrition to basically gain some energies, because the patients get really debilitated. So high calories and vitamins. Also, small and frequent meals because they get tired. So try to balance that activity with rest. Analgesics for pain or fever, cough suppressant, mucolytics, which thin mucus, so that way you can give them expectorants and expectorated, bronchodilators, and steroids if need to. So let's talk about the antibiotic therapy. Guys, there is a lot of antibiotics that could be used. Sometimes more than one is used. And so in your book, there's all these classes. I have put here the most, we're going to call them the most common classes: microlates, tetracycline, fluoroclinoids, B-lactams, and vancomycin. I have given you here the most common things that you need to know about them, and the most common generic names under each classification. Microlates and amycin, erythromycin, azithromycin, they could cause palpitation, chest pain, QT prolongation, nausea, vomiting. Tetracyclines, one is doxycycline, and that Klein, nausea, vomiting, could cause GI upset, reflux. One important thing is that you do not take it with any dairy products, iron preparations, or antacids. Then you have your fluoroclinoids. It's hard for me to say those words. So you're not alone. They're hard to say. They in fluoxetine. Levofloxacin is a common one. Levaquin. Again, it causes insomnia, depression, restlessness, QT prolongation. The B-lactamams, you have these are derivative of like penicillin. So you have a lot of allergic reaction to these. Here are your amoxicillins, Rocephin. And then you have your vancomycin. This one is very commonly used for pneumonia. And something to watch out for is Redmond syndrome with it. And you have to draw vancomycin trough, which is the therapeutic level where it is, because it is kind of very harsh to the kidney. It can also cause ototoxicity. And so you have to, it's one of those like you have to monitor. In general, any antibiotics need to be switched to oral as soon as possible, as soon as the patient is able to do it and stable. Typically they're discharged not in IV, but in oral antibiotic. The antibiotic regimen is based on the culture, so they might start maybe on amoxicillin and then realize, oh, it's growing MRSA, let's switch it to vancomycin. So, it depends on what's growing. The client needs to finish all antibiotics. The antibiotics can cause diarrhea very frequently, so giving a probiotic is very helpful, because when a client takes antibiotic, it kills this good bacteria that we have in our gut, because the antibiotic doesn't know what good and bad bacteria is. And so that leads to diarrhea, and so giving a probiotic replaces those good bacteria that we need in our digestive system. Always monitor kidney function with any antibiotic, honestly, because they tend to be filtered through the kidney, and antibiotics take 72 hours to reach therapeutic threshold. So we need to advise our patients that if they don't feel better within 72 hours, they might need to tell their doctor, because maybe the antibiotic needs to be changed. So let's talk about Redmond syndrome. So Redmond syndrome is whenever you infuse vancomycin in a pretty fast rate. And so it's a rate dependent infusion reaction, not really a true allergic reaction. And so you get literally this exact thing. The Redmond syndrome is called that because the patient turns red from kind of chest up. They get this flushing, redness of their skin, itching, and they could get some shortness of breath, hypertension if it's worse. The treatment here is to stop the infusion and administer antihistamine right away, like Benadryl, and either restart it at a lower rate or change it, which is the most I would say the most smart thing to do. Change it to a different antibiotic. Of course, you're going to be contacting your doctor. I've seen this happen once in my career, and it was not because it was fast. It was because the patient was actually allergic to vancomycin. Okay, so what does a nurse need to do in general? Well, we need to monitor vital signs. If we don't monitor vital signs, we don't know if the patient is declining or changing on their status. Elevate the head of the bed, assess for swallowing difficulties or decreased level of consciousness, promote oral care, brush your patient's teeth. Again, they can aspirate saliva, and that on its own is infectious. Collaborate with physical therapy to regain strength on the patient. They get very debilitated in bed. They say that a day in the hospital is 7 days in bed. Collaborate with respiratory team to be doing the breathing treatments, chest physiotherapy, or anything that the patient needs. Since they're going to be on oxygen a lot, you can add humidifier to the oxygen because it dries their mucosa. Another thing to watch out for is whenever you have oxygen on a patient, the nasal cannula or their BiPAP or the whatever, can lead to skin irritations or skin like wounds. And so you always want to check behind their ears and right here on their nose, and check for those skin problems. Educate the patient about stopping the smoke, and encourage the vaccine. Complications of pneumonias are pleuritis, which we're going to talk about it, pleural effusion, which we're going to talk about it, ATELECTASIS, which we're going to talk about later, bacteremia, sepsis, or shock. We don't really go over much of shock or sepsis here in adult. You're going to get this in complex, but in general is an infection of the blood and your vascular system collapses. And acute respiratory failure, again, we don't touch this in adult, we touch it in complex, but whenever your lungs can't anymore, they just stop exchanging and your respiratory system collapses. Here is a easy to read picture for you guys. And then let's talk about pleurisy or pleuritis. This one is an inflammation of the pleural cavity. So we have this kind of sac around our lungs that protects the lungs, and they get inflamed. And there's different reasons why they can get inflamed. Could be an infectious disease. It could be cancer, autoimmune disorders, trauma, even medications. But after pneumonia, someone can develop pleuritis as a complication. And so they basically manifest with this abrupt, sharp pain that is aggravated whenever they take a deep breath during inspiration. They feel this kind of sharp, kind of stabbing, abrupt pain. So therefore, they start compensating by breathing slower, shallow, and kind of like short beats, like, but it's shallow. Okay, so they start breathing little, but shallow, I guess, if that makes sense. I know I don't want to confuse you. It's like that, like just little bitty breaths. Whenever you hear it on auscultation, you hear what we call pleural friction, or a rub sound, and it sounds like a squeaky door. And to treat it, you just identify the cause and treat it. Let it subside, let it get better. You just support the patient based on their symptoms, so give them a lot of rest. You can give them pain medication, especially NSAIDs, because like Advil, because that helps with the inflammation of the pleural. And splinting the area of their chest if they're going to take the deep breaths or cough, so that way that it doesn't hurt as much. So splinting or laying on the affected side helps. NSAIDs, pain medication, rest, and just find what's causing it and treat it. Atelectasis is a lung condition where your alveoli are collapsed and they lose the air, which again is one problem that leads to pneumonia. And it could be another related to other diseases that we're going to talk a little bit later on. So you hear decreased or absent lung sounds, and dull sound on percussion. Typically, I mean, it's rare that you're going to be percussing your patient. You're mainly going to hear this decreased, dull, and diminished breath sounds. The cause is obstruction of the small airways with secretions, or not taking deep breaths, like surgical patients, or just the secretions obstructing the alveoli. So that's why I put here that the risk are patients that are in bed, or post-operative, or pneumonia. How do you treat it? You take deep breaths, you cough, you ambulate, and you get these patients moving as soon as you can, and you promote the insurospirometer. I work at a unit that is post-surgical. So all my patients come after surgery, and the patient hasn't even arrived in bed, and the respiratory therapist already has an internal spirometer and IS there set ready for whenever they get there. Within minutes that they get to the room, they're doing their IS, because we know that that's a risk. Okay, so these are little short problems. The next one is pleural effusion. And pleural effusion is an abnormal collection of fluid in the pleural space or cavity. I mentioned to you that after pneumonia, you can develop a pleural effusion, and then it collects with fluid, pushing the lung up, and so that way they can breathe and take the deep breaths, and also the exchange of carbon dioxide and oxygen doesn't happen. And at times we need to drain this fluid. And so anyways, they get this cough, sharp, non-radiating pain during inhalation, decreased breath sounds, shortness of breath, and dull sound on percussion. So the most commons are going to be the decreased breath sound, shortness of breath, and sharp non-radiating pain. You treat it by treating the underlying causes, because it's usually a complication. And then you can either eliminate the fluid giving diuretics, which in cardiac, you're going to learn all about diuretics, or a thoracentesis, which is a needle in the back to the cavity or pleural space and removing that fluid. You want to elevate the head of the bed, you want to give them oxygen, and you want to treat that underlying cause, which most of the times is like an infectious disease, so antibiotics. So pleural effusion is a problem. It's really not a disease. It's more of a complication or a problem in the respiratory system. Okay, let's talk about big tuberculosis. What is tuberculosis? It's an infectious disease that mainly affects the lung parenchyma, again. However, it can spread to other parts of the body, like the brain, the kidneys, and the bones. It is spread through close and frequent and prolonged exposure. It is airborne, just in the air. It is caused by this infectious agent called Mycobacterium tuberculosis, which is a gram-positive acid-fast bacillus that grows slowly and is very sensitive to heat and light, ultraviolet light. And so there's different risk factors that leads to tuberculosis. For example, homeless people, residents of urban areas, foreigners, people that work in the healthcare or prison, drug users, poverty, and people that are immunocompromised. Now, here in the United States, we don't see this that much unless there's someone coming from a different country. But in other countries, it's still, it's still prevalent. I relate tuberculosis to what's going on right now with COVID a little bit. It is similar on kind of how it's spread in the uses, the stuff that we're using, or originally when COVID started, what we were using, because we didn't know a lot of it. And so you're going to see, as we talk about tuberculosis, that a lot of few little things, some things are similar to what you're hearing of COVID. Here's a little bit of pathophysiology of tuberculosis. It is particles that spread after being cuffed up or expectorated. They evaporate and they leave this little nuclei for minutes or hours. And then the little particles, you can inhale them or get them inside your body. They move it into your bronchioles. Then an inflammation happens. And then the bacteria, it's engulfed, it's like circulated by the T cells that are our fighter cells, and they basically calcify them and encircles them to try to kill the bacteria. And so they call those the gen lesions, and those are what you can see in the x-rays. Now, however, when on weak immune system, the bacteria breaks the wall of the T cells and then they start spreading everywhere else. It's really not considered highly infectious because the transmission requires close contact and frequent and prolonged exposures. So because of that, it's not considered highly infectious. There are different classifications. And so in your book on page 510, you'll see the classification from 0 to 5, as well as there is a difference between latent tuberculosis infections versus active tuberculosis infections. And I put a chart here. So you'll see latent tuberculosis, you have no symptoms, you do not feel sick, you cannot spread TB. However, your skin or your blood test comes positive, and you need a specific treatment for latent TB. Now, however, on active, you do have symptoms, you feel sick usually, you can spread tuberculosis, your blood and all that comes positive, your sputum comes positive, your chest x-ray is abnormal, and you need treatment for active TB. How does it manifest? Well, different symptoms here, but dry cough that can lead or can progress to productive cough for more than 3 weeks. You have this fatigue, you have anorexia, you have night sweats, weight loss. You have in late symptoms this sputum with tinged blood or stained blood. Those are very hallmark signs of TB. Typically, symptoms don't appear from 2 to 3 weeks after the infection. And so it's not something that you're going to see right away within days. We diagnose it by the standard method, which is the tuberculin skin test. You all have had one of these, I know, or a T-spot or a chest x-ray, because all nursing students and all healthcare providers have had some of these tests at one point or another. But the tuberculin skin test is the standard method. They inject the small little amount of protein into that intradermal part of the forearm. Your results are read within 48 to 72 hours, and we look for induration, redness, and then it's measured in millimeters. And depending on the size, then they say you do or you don't. The T-spot looks for, basically it detects gamma produced by the T cells, and so a response of the immune system. And then on the chest x-ray, you look for those gone lesions or encapsulated granulomas. The sputum cultures are your gold standard diagnostic test because they're able to see that acid fast bacillus bacteria. They're able to culture it. And so now you need 3 consecutive specimens collected for 8 to 24 hours in intervals or apart, and can take up to 6 weeks to get results. So although it's the gold standard, it's not one of those, let's go get the sputum cultures right away. They might do other things meanwhile. To treat it, again, it depends if you're latent or active, but in general, you get these medication, anti-tubercular medications, and they're pretty harsh in the liver. So if you see here, I try to color code certain things so you can kind of help you memorize them. But if you don't remember anything else about TB medications, remember they're harsh on the liver, so they can cause hepatitis and elevate your ALTs and your ASTs, and they can change the color of your urine, tears, sweat, and sputum. So if you notice the ones with the R, they start with R, they have this discoloration. The one that starts with E, you have eye toxicity, so it decreases your discrimination of green and red colors, and pretty much all of them affect the liver and cause hepatitis. They can be combined with other antibiotics like streptomycin, aminoglycosides, and fluoroquinoids. So again, the therapy is extend, and sometimes there are multiple of these. One thing to know about the treatment is that the treatment is outpatient, and because of the population of the individuals that get tuberculosis, it needs to be an observed therapy to make sure compliance is it's done, basically, because non-compliance of people not taking the medications is very common. Think about the population. They're homeless, they're IV drug users. They can't afford these meds. They live in the street. They're under deserved population. So, you know, it's common to see the individuals not wanting to take the meds. The first 2 weeks after starting the treatment is when patients are not considered contagious. So those first 2 weeks are still considered contagious. You want to educate the patients to restrict visitations and avoid public transportation and public places, wash their hands, oral care, do good hygiene etiquettes, and don't be like coughing everywhere, kind of like what we're seeing with COVID right now. What do we need to do as nurses? Well, we need to assess for signs and symptoms of tuberculosis and recognize them early. If you suspect or you have someone that you think is positive, isolate them immediately. Anyone that is not confirmed but is suspecting is treated as if they're positive, just like what we've been seeing with COVID. They're placed in airborne precautions in a negative pressure room. At the beginning of COVID, we were putting our patients in negative pressure rooms where the air, as you see on this picture, the air comes from the hall and it's basically taken out of the room. And then the people that enter the room enter to one single door, and it's locked or closed at all times. You wear your N95 mask, just like we're doing with COVID. They're called a high efficiency particle air mask. And that way it filters this very, very contagious particles. You provide oxygen if needed. You elevate the head of the bed. You do bed rest and energy conservation. High carbohydrate, protein, vitamin, calorie diet. Small frequent meals. Hydration. You can give them bronchodilators, corticosteroids if they're having trouble breathing. And you contact public health because it is a public health concern. Just like COVID. Cover your nose, mouth with paper, and then dispose it in a paper bag or down the toilet. Meticulous hand washing, just like in COVID. And minimize lengthy visits to other parts of the hospital, like radiology. Okay, and then last but not least is environmental lung disease, which is resulting from inhaled dust or chemicals. It damages the lungs, and so the damage is based on how much of this toxin or inhaled dust or chemical did you get, the substance, the duration, and there's different types that I listed here: pneumoconiosis, chemical pneumonitis, and sensitive pneumonitis. The manifestations, you're going to see them in years. This is not something that happens one day to another. This is prolonged exposure: dyspnea, cough, wheezing, weight loss, and reduced vital capacity. The complications of this is COPD, cancer, and heart failure. And you're going to hear in another video what COPD, these obstructive diseases are. But to treat it is preventing. And that's why we have agencies like OSHA and NIOSH to protect the employee from the particles and so on of these companies or mines. That is why we have to wear special masks if we are working in certain jobs, and early diagnosis. But if you are diagnosed with environmental lung disease, then you are on oxygen, bronchodilators, steroids, you're giving the vaccine, pneumococcal vaccine, and you are encouraged to stop smoking. Okay, that was quick because I'm reaching that hour and it's a long video, but again, my references are from our textbook and all my images are from either Google or the textbook. I hope this was helpful and I will see you in the next video.